Welcome. Today we're diving into Huntington's disease, a devastating neurodegenerative disorder that impacts movement, cognition, and mental health. Join us as we explore its intricate causes, effects, and the latest advancements in understanding and managing this challenging condition. Huntington's disease, often abbreviated as HD, is caused by a genetic defect on chromosome 4. This defect involves an expanded SAG repeat within the Huntington gene, also known as HTT. SAGE stands for cytosine adenine, and these three DNA building blocks repeat themselves multiple times. Normally, individuals have around 10 to 35 of these repeats. However, in people with HD, the CAG repeat is expanded, often exceeding 36 repeats. This expanded repeat leads to the production of an abnormally long Huntington protein, which is the root cause of the disease. The mutated Huntington protein aggregates and accumulates in brain cells, particularly within the basal ganglia and the cortex. The basal ganglia, crucial for movement control, suffer significant damage, leading to the characteristic motor symptoms of HD. Neurons in the cortex, responsible for higher-level cognitive functions and emotions, are also affected, resulting in cognitive decline and psychiatric disturbances. This accumulation disrupts normal cellular function, interferes with neurotransmitter signaling, and ultimately leads to neuronal death. The progressive loss of these neurons is what drives the relentless progression of Huntington's disease. Huntington's disease is estimated to affect approximately 3 to 7 people per 100,000 in populations of European descent. However, the prevalence can vary across different populations. It is an autosomal dominant genetic disorder, meaning that if one parent has the disease, each of their children has a 50% chance of inheriting the gene and developing the disease. The age of onset typically falls between 30 and 50 years, but it can occur earlier in life, known as juvenile Huntington's disease, or later, after age 60. The signs and symptoms of Huntington's disease are diverse and can vary significantly from person to person. They are broadly classified into motor, cognitive, and psychiatric symptoms. Motor symptoms include chorea, involuntary jerky movements, dystonia, sustained muscle contractions causing twisting and repetitive movements or abnormal postures, rigidity, slow or abnormal eye movements, and impaired gait posture and balance. Cognitive symptoms encompass difficulties with planning, organizing, and prioritizing tasks, impaired judgment and decision-making, difficulty focusing or concentrating, and slowed processing speed. Psychiatric symptoms can include depression, irritability, anxiety, obsessive-compulsive behaviors, apathy, and even psychosis. The specific combination and severity of these symptoms vary across individuals and change as the disease progresses. Diagnosis of Huntington's disease typically involves a combination of neurological examination, family history assessment, and genetic testing. A neurologist will evaluate the individual's motor skills, cognitive abilities, and psychiatric status. Family history is crucial, as HD is a hereditary disease. A definitive diagnosis is made through genetic testing, which detects the presence of an expanded CA repeat in the Huntington gene. Genetic counseling is strongly recommended for individuals with a family history of HD to help them understand the risks of inheriting the gene and make informed decisions about genetic testing and family planning. While there are no definitive subtypes of Huntington's disease based on the underlying genetic defect, it's often clinically categorized by age of onset. Juvenile Huntington's disease presents before the age of 20 and often manifests with more rigidity, seizures, and cognitive decline compared to the adult onset form. Adult onset Huntington's disease is the more common presentation, typically appearing between the ages of 30 and 50, characterized by the classic triad of motor, cognitive, and psychiatric symptoms. Currently, there is no cure for Huntington's disease. Treatment focuses on managing the symptoms and improving the quality of life. Medications are available to help control chorea, such as tetrabenazine and deutetrabenazine. Other medications, like antidepressants and antipsychotics, can help manage psychiatric symptoms. Physical therapy, occupational therapy, and speech therapy can help improve motor skills, maintain function, and address communication difficulties. Supportive care, including counseling, support groups, and social services, is essential for both the individual with HD and their family members. As Huntington's disease is a genetic disorder, there's no way to prevent its onset in individuals who inherit the mutated gene. However, genetic counseling and testing are crucial for individuals with a family history of HD. This allows them to make informed decisions about family planning. Preimplantation genetic diagnosis, a PGD, is an option for couples undergoing in vitro fertilization. It involves testing embryos for the HD gene before implantation, allowing them to select embryos that do not carry the mutation. The prognosis for Huntington's disease is unfortunately progressive and ultimately fatal. The average lifespan after the onset of symptoms is approximately 15 to 20 years. However, this can vary significantly depending on the severity of the disease. the age of onset, and the individual's overall health. Recent research is focused on developing disease-modifying therapies that can slow or halt the progression of HD. Several clinical trials are underway, exploring potential treatments like gene-silencing therapies that target the mutated Huntington gene. These experimental approaches hold promise for future treatments that may significantly improve the lives of individuals affected by Huntington's disease. Research continues in the hopes of one day finding a cure.